Thank you very much for having me. My name is Shahid Bukhari. I'm a doctor training in clinical pharmacology at Chelsea Westminster Hospital. I'm just here to give yourselves a little bit of a brief sort of presentation on some service evaluation that we've done at Chelsea Westminster, more so around Paxlovid and its potential for DDIs and how we actually managed that. So yeah, hopefully it provides you with some benefit, and if not, at least it heralds home time pretty soon. So just to give you a brief overview of what we'll be covering, and just to mention that I have no sort of disclosures. So starting off with Paxlovid, I've just given a few lines with regards to just information about its mechanism of action. I'm pretty aware that a number of yourselves will be quite familiar with its mechanism of action, its pharmacodynamic and pharmacokinetic profiles, and a number of yourselves will be quite familiar with prescribing it as well. But just to kind of furthermore to what Katia and Alice kind of said very eloquently, I guess the point I want to really drive more so is around Ritonavir, in this case, around its potential for DDIs through its potent inhibition of CYP3A4. And therein lies the kind of the struggle that we have as clinicians. So given that it lends itself to a list of potential drug-drug interactions, when it comes to kind of the eligibility for receiving Paxlovid in hospitals, you know, the patient cohort that normally tend to be referred to them tend to have quite a high sort of burden of co-medications as well, as previously has been mentioned. And these will kind of vary between things like cardiovascular therapeutic agents, inhaler therapies, and analgesics, to name a few. And a number of these will have potential to interact at varying degrees with the Ritonavir, depending on their metabolism. So what we essentially done, based on this potential for drug-drug interactions, we need systems in place, especially in hospital and especially in community settings, to be able to accurately record patients' co-medications, to be able to identify the DDI potential, and to then furthermore identify or risk stratify those DDIs and manage patients accordingly. So as a result, we really need a medication review when it comes to prescribing Paxlovid. At the moment, at the time of writing, there was no sort of agreed national audit standards when it came to actually this whole prescribing process. So what did we do? Essentially, we carried out a service evaluation at Chelsea and Westminster. This is between sort of September and December of last year. And we looked at patients that were referred to the COVID medicines delivery unit at Chelsea. So those at the CMDU. So these are basically patients with COVID-19 confirmed, non-hospitalized at the highest risk of hospitalization. And there's a number of guidelines that have been previously mentioned with regards to those patients which are eligible. So where do we get the data from? So the patients that were referred to those CMDUs went into a pharmacy database, and then we pulled that ID information from that pharmacy database and used our local electronic patient records to kind of find out those consultation notes with regards to what happened when they were referred to the CMDU, with regards to what were their co-medications, what was done about said identified DDIs related to those co-medications, and how this was managed. So in cases where there was a lack of clarity, then in those cases we used another system known as the NHS Summary Care Record to further corroborate patients' repeat prescriptions or long-term medications where it wasn't very clear. So then comes the point where how do we go about kind of looking at the risk stratification process of this kind of service that we have? And we cross-examined the CMDU's method of sort of risk stratifying through the use of the Liverpool COVID interaction checker. They were also using it, but we essentially were using it just to kind of check how well they're essentially adhering to it. And what's previously obviously mentioned is the traffic light system that the Liverpool website uses to subcategorize the severity of the DDI. So red, for example, being avoid co-administration, amber being a potential interaction that may require management, yellow essentially highlights a potential weak DDI which we don't necessarily need to worry about, and green where there's no DDI expected. And I've provided on the right side just kind of, and then what the Liverpool website shows when you've given in, when you punch in a couple of co-medications there. When we looked at the risk stratification process that was carried out, then we looked at what do they do about that risk stratification process. So did they provide advice? Did they say, hold this medication? Did they say, carry it on? So we essentially looked at that as well. So essentially the results are that there are, around that period between September and December, there are about 410 patients that were referred to this CMDU. Now, I have to preface this already that patients who were referred, this was during a period where there were multiple options when it came to sort of treatment of COVID. So this includes molnupiravir, sotrovimab, monoclonal antibodies. So it's not just Paxlovid that we're looking at, but this is what we're focusing on today. So amongst those 410 patients that were referred, 208 patients were eligible for Paxlovid therapy. And out of those 208 patients that were eligible, 111 had a potential DDI identified. Now, if I'm going to count purely on the basis of just pure DDIs themselves, rather than the number of patients harboring those DDIs, then we come up to a number of 184 DDIs that we identify, regardless of the severity of that DDI. So, just to start off with the red DDIs themselves, so we identified about 13 patients in total out of that cohort with a documented red DDI. And I provided sort of a breakdown of the specific drugs in the pie chart adjacent. What was done about those red DDIs, essentially, if I'm going to count again as per only the interactions, then that's 14 red DDIs out of the 184 total DDIs. What was done about it? Well, 57% of those did not have any documented advice to hold co-medication. The rest of them did. If I move over to amber interactions, or amber DDIs, there are a total of 84 amber DDIs identified. I provided a breakdown of that in the pie chart adjacent, highlighting the medication that was identified. What was specifically done regarding the amber interactions, essentially 56 of these 84 amber interactions that were identified did not have documented advice to hold therapy. 33% had documented advice to hold the interacting agent, 5% were advised to continue with the interacting agent, and then the remainder 6% had a documented conversation regarding the risks. Finally, moving on to the yellow interactions, there are a total of 86 yellow interactions that were identified. This is sort of a breakdown is given in the pie chart adjacent as well. So what does this essentially tell us? Well, we've seen that there's quite a potential for drug-drug interactions. It's previously been mentioned, and it's been reiterated more so within the service evaluation, that there's quite a high potential for drug-drug interactions, especially within the cohort of patients that normally are eligible to receive the Paxlovid. It also highlights the necessity of having systems in place in which can recognize DDIs and as a result risk stratify. And this can allow us then to mitigate potential adverse drug reactions as a result of that sort of potentiation because of the Ritonavir. So limitations with regards to this service evaluation, they're mostly around sort of two areas. One was we were using the Liverpool COVID interaction checker, which obviously has been highlighted earlier, and it's an amazing resource. But obviously there were still certain medications that we found that patients were on which were not on the interaction checker. These are more specifically certain herbal or supplemental medications that they took on a daily basis, which you might quite rare. And then aside from that, things like certain chemotherapeutics and immunotherapeutics. Then more so moving on to sort of the human factor side of things, we're looking at the CMDU itself. It's in a period where, there's issues with staffing, there's issues when it's just newly been established, so practices may not have been cemented as much. And at the same time, if you've got people who, they're trying to fill in a shift when it comes to this kind of CMDU shift, they might not essentially have gone through the training as adequately, so they might have just kind of picked up a few tips from a colleague, and as a result, they're not fully au fait, as it were, when it came to actually properly documenting co-medications. So as a result, we have mistakes such as clinicians documenting the drug class instead of the drug specifically. So they write COCP instead of the specific contraceptive, or eye drops, for example. And then in addition, there may have been discussions about the risk, but it wasn't documented, and that also could reflect in issues with staffing or earlier kind of trained stuff coming in earlier on and not sort of being aware of how the system works. So finally, to conclude, this sort of highlights the need for development of standards for the assessment and management of potential DDIs of Paxlovid. is really crucial. Essentially, as Paxlovid is becoming increasingly ubiquitous, more so now in community settings. So these are general physicians that are essentially going to be coming across, patients with co-medications. And as a result, they need to kind of risk stratify accordingly. And as a result, from our study, it showed room for improvement, but it also emphasizes the importance of developing guidelines and audit standards to optimize CDI assessment and management. And that's it for me. Thank you very much.